Good morning and welcome everyone. I am Dr. Jerean Grau, and I want to thank Dr. Jessica Weber and the L Center of Excellence for giving me this opportunity to talk to you today about certain medications that we use to treat children with autism spectrum disorder. I am by education and experience a psychopharmacologist, which quite simply means that I have specialized in the study of medications used to treat psychiatric disorders, including autism spectrum disorder. Now, I know this topic can sometimes be intimidating and maybe even boring to some people, but I hope to present my information in a way that everyone can understand. I've always thought that it is the role of the instructor to make a topic so interesting that the listener will want to learn everything they can about that subject. And I also believe in presenting information in creative and imaginative ways, including using humor, so that information is easier to understand. For many years, I've been fascinated by the brain, how it works brilliantly when well, yet can be absolutely devastating and destructive when injured or altered. And I hope to help you understand something about how the brain functions and how medication can actually change behavior and thought. Today in particular, I want to discuss the medications that are used to manage behaviors, including agitation, aggression, irritability, and repetitive movements that are often problematic in children with ASD. We, unfortunately, at this time, have no medication to treat the core symptoms of autism. Behavior therapy is, of course, first-line treatment. But if that doesn't work or some fine-tuning is needed, we have two medications that have specific indications for use in ASD. And these are the atypical, or second-generation antipsychotic agents, aripiprazole, which brand name is Abilify, and risperidone, or Risperdal. And they have been used for some time and are generally helpful and safe. Rarely do any psychiatric disorders occur by themselves. For example, someone who has depression may also have panic attacks. A person with bipolar spectrum disorder may also have problems with anger management. Now, that's certainly true with children with autism, and managing the comorbid disorders is also why we use medication. So in addition to discussing the medication to manage disruptive symptoms of ASD, we'll briefly discuss medications to treat ADHD, anxiety disorders, and depression. Before we actually get started, I want to give you some helpful background information on what this presentation is all about.
Because you know it's all about that brain, neuroscience. It's all about that brain, neuroscience. It's all about that brain, neuroscience. It's all about that brain. Yeah, it's pretty clear. These drugs are brain food, and that their actions lead to cascades of true. 5 targets to do all the drugs chasing, all the psych drugs in all the same places. Or sometimes I pause, it wasn't real pause. The genes start to talk. If you get gene transcription, proteins go up. So no signal transduction from the bottom to the top. Yeah, research it told me it's It's all about that brain, about that brain. We're bringing circuits back to treat the symptoms you must know how to move. It's circuit-based and then you make it back to mechanisms so no signal transduction from the bottom to the top. Yeah, research it, tell me if that's just a nature gene. It's the epigenetic effects that you because you know it's all about that brain, neuroscience. It's all about that brain, neuroscience. It's all about that brain, neuroscience. It's all about that brain, because you know it's all about that brain, neuroscience. It's all about that brain, neuroscience. It's all about that brain, neuroscience. It's all about that brain.
And so that's what it's about. It's about the brain. And this was a focuser, as they call it, from the Neuroscience Education Institute, which is in San Diego, and they provide the most up-to-date information on neuroscience and psychopharmacology of anyone today. It is headed by Dr. Stephen Stahl. And his textbook is used by almost every medical school in the country. He, too, provides his information in creative, imaginative, and often very humorous ways. And this video you can certainly find on YouTube under NEI Global Focusers. The two medications that I previously mentioned to treat agitation, aggression, irritability, and repetitive movements in children are aripiprazole, Abilify, and Risperdal, or Risperdal. And as I mentioned, they're classified as atypical antipsychotics. Now, this does not mean we use them to treat only psychotic behavior, but they're used for a number of things and are very effective. But what do I mean when I say atypical antipsychotic, and how do they work? Well, first we've got to look at the history of antipsychotic agents. Chlorpromazine, which most of you have heard, I'm sure, our brand name is Thorazine, was first introduced in the early 1950s, not as an antipsychotic agent, but as an agent used to treat histamine disorders or in anesthesia. Fortunately, during trials with this agent, it was found that it could decrease aggression and agitation and improve or stop hallucinations and delusions. Now, it was found that chlorpromazine did this by reducing the amount of dopamine, which is a neurotransmitter, in certain areas of the brain. This led to the theory that psychotic behavior results because of an excess of dopamine. A number of typical antipsychotics, also known as first generation, followed chlorpromazine, including thioridazine or Mellaril, which we almost never use anymore, haloperidol, which is Haldol, fluphenazine, Perlixin, and a multitude of others. We still use Haldol and Perlixin, but the only reason we use chlorpromazine anymore is to treat intractable hiccups. These first generation or typical antipsychotics do not treat all symptoms of aggressive behavior or psychotic behavior, and they are not the same, of course, and had a multitude of side effects. Because of this, atypicals or second generation antipsychotics were developed, The first was clozapine, which was introduced in the 1990s. So these are all fairly recent. Risperidone, or Risperdal, came next, and then was followed by a string of others, including Zyprexa, Seroquel, Jerean, Abilify, and Latuda, and there are others, Saffris, and so forth. Now, they're called atypical because in addition to managing the actions of the typicals, they also improve other things. So they improve the agitation, aggression, and irritability, reduce hallucinations, delusions, and repetitive movements, but they also improve mood, improve the ability to think, the ability to focus and reason. They improve judgment, and they have far fewer side effects, and they're usually milder side effects. So in order to understand how the antipsychotics work, we must understand what happens in the brain. The human body has substances that transport impulses from one nerve to the other, from a brain to a nerve to an organ. These include dopamine. These are called neurotransmitters, or nerve messengers. And these include dopamine, serotonin, norepinephrine, acetylcholine, glutamate, gamma-aminobutyric acid, orexin, and there are many more that we have not yet identified, but we're certainly making progress every day. Dopamine is one of the most important neurotransmitters, and it is a major target of the antipsychotic agents. At this time, we have identified 5 dopamine pathways in the brain. This is a schematic from Neuroscience Education Institute and from Stephen Stahl's Essential Psychopharmacology. And to look at the different pathways, I'm just going to mention them here. The blue one is the nigrostriatal. The red one is very important. It's the mesolimbic. The purple is mesocortical. And the mesolimbic and the mesocortical are the two that have therapeutic effects when affected. And the orange one is the tuberoinfundibular. Now, if you think of the different pathways as roads through a region, then you'll understand that you're not going to have the same amount of traffic on all the roads, all the pathways. So you may have differing amounts at different times, but all of the traffic is dopamine. Now, the mesolimbic, the red pathways that we looked at, is very important in the production of emotion, pleasure, motivation, thought, and reward. It's on this pathway that when traffic gets too heavy or there's too much dopamine, aggression, agitation, hallucinations, and delusions may develop. Now, it's when the body by itself, when it has endogenous dopamine, excess dopamine, psychotic disorders will develop. When the excess dopamine comes from an outside source, such as cocaine or amphetamines, then we say the psychosis is from an exogenous dopamine. Now, both typical and atypical antipsychotics work at this pathway to block dopamine from sending too much information. And it's from this pathway that we improve the aggressive behaviors and hyperactivity that we talked about, and that we see with autism spectrum disorders. In talks that I've given to other patient and family groups and mental health professionals, I usually present a short live presentation about how this happens. I'm going to use a photographed skit today, and hopefully you'll understand what happens in the brain a bit better. So let me introduce my cast of characters to you. In the clear, large bubble ball is the brain. And we have endogenous, or just the right amount of dopamine, in this blue bubble ball. And then we have, and we'll call her E-dopa. Next to, or at the end, we have excess dopamine, or non-essential dopamine, this young lady and this young lady in the other two blue bubble balls. And in keeping with the superhero atmosphere of the entertainment industry today, I would like to introduce to you Super Rip, or Super Risperdal, and Super Pip, Super aripiprazole, or Super Abilify. In the normal brain, when you have essential or only the amount of dopamine that is necessary, the brain and dopamine pass information back and forth in a very controlled, very calm manner, and the brain performs to the best of its ability. When, for whatever reason, dopamine decides to enter the picture, the brain becomes hurried and can't answer all the impulses that it is getting. It may become rushed and flustered, and it's unable to send any messages back out. If this continues, then hope is all gone. You have an angry brain. You have a brain that is overwhelmed by too much dopamine. She may become aggressive and agitated and hyperactive, and even develop hallucinations and become paranoid and feel all dopamine is out to get her. So what do we do now? We make a call to Super Rip and Super Pip, and they come upon the scene quickly, and they wrestle and they fight non-essential dopamine. So they block the non-essential dopamine from getting to the brain. After this battle, because Super Rip and Super Pip have intervened, the brain is able to return to normal. And essential dopamine and the brain are able to interact and communicate again in a very controlled and calm manner. And the brain, again, is able to work to the best of its ability. And I just want to show you the young people who gave up their Saturday to come and be put into funny costumes and to be photographed to help us with this presentation. So remember, an excess of dopamine in the mesolimbic pathway causes the agitation, the aggression, the hyperactivity that we see in autism spectrum disorder, and the repetitive movements. By blocking that, we can improve those behaviors. Let's move on just a bit to the mesocortical pathway. Again, it's the purple pathway that we see right here that extends into the cortex, which is very important. A person's mood and the ability to think, make decisions, and have control valves is in the mesocortical dopamine pathways. It is thought that a decreased amount of traffic or dopamine here may cause the lack of attention and inability to focus that we see in ADHD, as well as decreased mood and ability to process thought and reason. The atypical antipsychotics, but not the typical, work in this pathway to increase dopamine. And they do this by activating serotonin, another neurotransmitter we'll talk about more later, which in turn increases levels of dopamine. If you think about the skit that you just saw, if you see the brain by itself, it's getting no dopamine at all. So what do we need to do? We need to call Super Rip and Super Pip again. And what they will do is bring dopamine into the region so that the brain will be getting communication. But they do it in a way that it is not too much information. So this is how atypical antipsychotics work to improve mood and thinking, to improve focus and attention, and to increase judgment. The nigrostriatal, the pathway in blue, and the tuberoinfundibular pathway provide no therapeutic improvement. They are important to know about because when they are affected by antipsychotics, they cause side effects. The nigrostriatal pathway is the one that causes movement disorders that we frequently see with typical antipsychotics, but not atypicals. When dopamine is blocked in this pathway, you will see rigidity of the face, of the facial muscles, of the body itself. You may see what we call the Parkinson shuffle, and even a tremor that you often see in a patient with Parkinson's disorder. In the tuberoinfundibular dopamine pathway, again, this is mostly affected by the typical, not the atypicals, but the typical antipsychotics, except for Risperdal, which does sometimes cause release of prolactin. And the tuberoinfundibular pathway regulates prolactin release. Prolactin is a hormone, and when it is increased, you can get breast enlargement and even milk production of the breast. Doesn't happen often. It's usually very mild. What we sometimes worry about is in young males who, of course, we don't want to have breast and certainly don't want to have milk, but that rarely happens in males. But they will develop breast sometimes, and that is occasionally a reason for discontinuing Risperdal. The fifth dopamine pathway, which has just been identified by actually the Neuroscience Education Institute and Dr. Stahl's group. At this time, we haven't named, nor do we know what it does, but we know it's there. So now that you know how the brain works, let's discuss the two atypical antipsychotics that have been approved for use specifically in autism spectrum disorders. And these are, as I've mentioned, Risperdal and Abilify, and they're approved by the FDA for treatment of irritability in ASD. And this irritability also causes the agitation and aggression in the repetitive movements that we see. Risperidone, or Risperdal, has been around for quite some time, since the early 1990s, and it is FDA approved to treat autism-related irritability in children from 5 to 16. It is an excellent medication, works very well, and is quite safe. You may see improvements in a week or even sooner, but it may take up to 4 to 6 weeks before full effects are seen. Dosing is ranged at 0.5 to 2 milligrams per day for children with autism spectrum disorders. And you want to start at the lowest dose and titrate upward. And you can do that as often as every day. And it can be given once a day, but generally works better in children to give twice a day, at least initially. We have 3 different dosing forms, tablets to swallow, and there are actually 8 different strengths. Tablets to dissolve under the tongue and let them, that way it gets into the bloodstream faster. And an oral solution at 1 milligram per milliliter. And interestingly enough, this oral solution is not compatible with Cola RT. Side effects are generally mild. You may see some drowsiness, which usually disappears over time. But if it does happen, the best thing to do is give it at bedtime. And this may change from a side effect to an advantage. We see weight gain in children, rarely in adults, however. But it's not the same kind of weight gain that other antipsychotics cause that lead to diabetes. This does not. And usually it can be controlled by diet modifications or increased exercise. As I did mention, Risperdal can increase prolactin levels and cause breast development. And usually the only time it is problematic is in young males. To discontinue Risperdal, it does need to be weaned. So you reduce it over a period of time. The next antipsychotic, Abilify, is not actually a second generation, it's a third generation antipsychotic, and we also call it a dopamine stabilizer. It is FDA approved for treatment of autism-related irritability in children from 6 to 17. It has just been approved for treatment of Tourette syndrome in children ages 6 to 18. It too, you may see some improvement in a week's time, but it also may take up to 4 to 6 weeks before full effects are seen. Dosing for Abilify is 5 to 15 milligrams per day in children with Autism Spectrum Disorder, and just for your information, 5 to 20 milligrams per day for children with Tourette's. As with the Risperdal, you start at lower doses and titrate upward. You increase dose with Abilify every 7 days if it is needed. It can, too, be given once a day, but twice daily, at least initially, may lessen any side effects that might be seen. Dosing forms are, as with Abilify, we have 3 different kinds for children. Tablets to swallow, and you can see the different strengths there. Tablets to dissolve under the tongue, 10 and 15 milligrams, and the oral solution, 1 milligram per mil. That can be mixed with essentially everything. You can put it in cola, you can put it in tea, juice, anything your child wants. Side effects are very rarely seen with Abilify, are generally mild, and may be lessened over time or by lowering the dose. I don't think I've ever heard of anyone complaining of nausea and vomiting, but it can occur, as can dizziness and insomnia. Abilify, unlike Risperdal, can be stimulating, so it should be administered in the morning, not at bedtime. Discontinuation of Abilify can be done abruptly. It can be just stopped. And that's because it stays in the body for such a long time, you don't have to wean it. If you have any questions about either of those, I'll take them at the end of the presentation. as I will any questions about the other medications that we're going to talk about for treatment of comorbidities. And rather than spend a lot of time talking about medications to treat ADHD in children with autism spectrum disorder, I want to remind you of what happens in the mesocortical dopamine pathway. That in ADHD, there's too little dopamine available. The stimulants, Ritalin, methylphenidate is the generic. We have many different brand names, Concerta, Metadate, Aptensio, and the transdermal formulation of Daytrana directly increase dopamine in this pathway. And so they normalize behavior by doing this rather than stimulating behavior. All stimulants may decrease appetite and cause weight gain, or weight loss, some more than others, often significantly. And Concerta, for example, may cause more weight loss than some of the others. And because they're stimulants, they should be generally given before 4 p.m. in the afternoon. And once again, if you have specific questions, I will be happy to answer them at the end of the presentation. Another medication to treat ADHD is atomoxetine, or Strattera. This is what we call a selective serotonin reuptake inhibitor, which is used in treating antidepressant. This one is not, however. It is not activating, nor does it cause weight loss. But if you remember when I talked about the mesocortical pathway, the atypical antipsychotics stimulate serotonin, which in turn will increase dopamine. And that's how Strattera works. We have not found it to be quite as effective as the stimulants, but it is certainly a good medication and certainly has its place in treatment. Another agent that we use is clonidine, or Catapres. It is an antihypertensive agent, directly acts in the brain, but we don't know quite how it does act. It has an associated agent called guanfacine, or Intuniv, that also is used, and very similar. It's an alpha adrenergic agent, but we don't know how it works either. Moving on to anxiety disorders, which frequently occur in children with autism spectrum disorders. These include generalized anxiety disorder, panic disorder, social phobia, obsessive compulsive disorder, and post-traumatic syndrome disorder. When these occur, there is a deficit of serotonin. Serotonin is a very important neurotransmitter. We find pathways throughout the body, certainly in the brain, but throughout the body as well. And we have identified 35 of them at this time, all with different actions. And we are quite certain there are others as well. But to control anxiety disorders, we use medications that increase the amount of serotonin. And these include the selective serotonin reuptake inhibitors, or SSRIs, and the newer class, SNRIs, or the selective serotonin norepinephrine inhibitors. In children with autism spectrum disorders, one of the most effective SSRIs is sertraline, or Zoloft. We also can use Celexa and Lexapro. And I'll just mention that Prozac is not as helpful in anxiety disorders as it is in depression. And that's because Prozac is stimulating. And we'll talk about that as soon as I move on to depression. The SNRI that we use that's very effective is venlafaxine or Effexor. And even though it not only increases the level of serotonin, but also norepinephrine, it is very effective when used in anxiety disorders. A directly stimulating serotonin agent is buspirone or Buspar, and it also has effectiveness in being used in treating anxiety disorders in children with autism spectrum disorders. There are other agents, of course, in the different classes that are used, and these in particular are approved for use in children, and but not every child reacts well to one medication. What works for one person is certainly not going to work for another one. So it is trial and error in many cases. You try and try and try until you find what works well for a particular person. And I just want to mention there isn't a medication we use to treat obsessive compulsive disorder, and it's called clomipramine or anafranil. For whatever reason, and we use it all the time in children, but it doesn't seem to be effective in children who also have autism spectrum disorder. The next comorbidity I will talk about is depression. And in depression, we see a deficit of dopamine, serotonin, and norepinephrine. And we've talked about dopamine quite a bit and a little bit about serotonin, but now we have to include norepinephrine. And I'm very passionate about people understanding that psychiatric disorders are truly medical disorders. So I like to compare depression to diabetes. And if an insulin-dependent diabetic does not get his insulin, he may get very, very sick and may actually die. And the person has depression, if they don't get their antidepressant, then they also may get very, very sick and very physically ill. Unfortunately, the depressed individual may hear all sorts of things such as, oh, just get over it, or you need to toughen up, or don't be so sensitive, what's wrong with you? But it's just as important for someone to receive medication for depression as it is for someone to get their insulin every day. Now, at this time, we don't have a single medication that will increase levels of all three neurotransmitters. SSRIs, as I mentioned, when we talk about anxiety, are first lines of treatment for depression. Agents are first choice for treating depression. Prozac is the one we use most in children. So as with anxiety, we use Zoloft as well. And of course, there are many others that we can use. Prozac, as I mentioned, is an excellent medication, but it may cause anxiety and should not be taken at night, can certainly cause insomnia, but it works quite well and is the first SSRI to try in children with autism spectrum disorders. Selective serotonin norepinephrine reuptake inhibitors, or SNRIs, increase both serotonin and norepinephrine. By increasing norepinephrine, you improve the ability to think, or cognition, and you often see this in depression. Someone's ability to reason will be altered or will slow down. Many physicians use an SNRI first, not waiting for a failure of an SSRI. It really depends upon the severity of the depression and the experience of the physician. As I mentioned with anxiety, venlafaxine or Effexor is certainly effective and often used. And duloxetine, a newer SNRI or Cymbalta, is used as well. Both of these are very safe and very effective. We have two medications that specifically increase levels of dopamine. These are bupropion, or Wellbutrin, and mirtazapine Remeron. Wellbutrin is used often in children. We see good effects when it's used to treat ADHD, for example. Good effects in treating depression, usually as an adjunctive agent, not by itself. Mirtazapine Remeron we rarely use in children. Sedation can be quite severe, and weight gain can be quite severe as well. I realize we have covered a great deal of material here, but what I've given you has just scratched the surface in a very, very simplified way. We have wonderful research going on. We're making discoveries daily that will change and improve the care of people with psychiatric medical disorders. At this time, we don't have a single medication to treat core symptoms of autism spectrum disorders or to prevent its development, but we are diligently working to find new treatments and find reasons to why autism spectrum disorders occur. With so much research and so many dedicated people working to find cures, our goal is to achieve not only response, but remission. I've been working with psychiatric disorders for many, many years, and with children with autism spectrum disorder, and have seen huge improvements. When I first started working in 1980, we had no medications to give children with ASD, and behavior therapy wasn't used either. So times were very, very sad. But we now are achieving, it seems to me, amazing results with behavior therapy, with alternative medicines, diet plans, vitamins, and some medications. I must highly commend the L Center of Excellence for its vision for the best care possible for children with ASD. And the L Center is doing remarkable work and achieving great, great things. I want to close with a video that stars Dr. Andrew Cutler. He is former chief of the Department of Psychiatry at University of Florida, and currently president and CEO of the Florida Clinical Research Center, a company that is doing clinical trials with new psychiatric medications. He did work with Intuitive, for example, and was one of the researchers that led to its being marketed. Dr. Cutler, I have never seen in anything but a suit and tie. He is very well respected and very reserved often. Now, the other members that you'll see in this video are either well-respected psychiatrists or psychologists, one from Johns Hopkins, one from University of California, San Diego School of Medicine, and the other is a psychiatric resident from UCSD. What you see is probably different than what you will expect, but they are working in ways to advance awareness, to help people understand that psychiatric disorders are truly medical and that the goal of treatment is complete remission. After the video, I will be happy to answer any questions that you may have. Well, if Dr. Cutler ever wants a new career, we know what he can do. And who said psychopharmacologists are boring people? Um, if you would like more information, I highly recommend that you join the Neuroscience Education Institute at neiglobal.com. And all of my specific information about medication came from Stephen Stahl's Essential Psychopharmacology Prescriber's Guide. I want to give the L Center of Excellence my thanks for letting me come and hopefully give you some insight to what happens with these medications. Does anyone have any questions? If not, if anyone would like more information or to get in touch with me, I'm sure if you contact the L Center, they will have my information, and I will be happy to talk to anyone or give any information that you might need. Thank you so much. I hope you enjoyed it. Thank you, Shelley and Pam.